right. Well, listen, thank you so much, both of you, for coming out tonight to join us for this program. Um, it's about 6:02 right now here in Boston Eastern Time and 5:02 your time, Dr. Tucker. So
Okay.
let's start. You guys ready?
I'm ready.
All right. Folks, welcome to this new collaboration between MyHeartMD and CardioVisual. Now, this series, like we've talked about before, is one of collaboration, and truly a collaboration, because it's going to, encompass care all the way from EMS, from patients in the pre-hospital arena, all the way down to the experts such as Dr. Tucker, taking care of them and fixing them definitively. It's going to span the entire spectrum there of care. And for that, I really thank my friends at CardioVisual. The faculty has been awesome in partnering up with us here. This series is called Heart Heroes, Frontline Care. And like I said, the focus is on this collaboration between healthcare professionals. Now, Dr. Paul Tucker is an interventional cardiologist in Austin, Texas. And Ben Pasatolo is a paramedic over here in Boston. Ben has a huge, extensive repertoire expertise in EMS and all kinds of things. And so I'm really thankful that he's here with me to share his thoughts right here in Studio 124. Ben, thank you for being here. So let's get right into this case. All right, this was you've all seen the EKG. This was a 45-year-old marathon runner who was running the marathon, and right about mile 20, he developed chest pain, fatigue, so much so that he couldn't actually finish the race, and he stopped. Paramedics were right there. They got a 12-lead ECG, and that's what you saw on the previously today. It shows, obviously, this terrible, terrible EKG done, and there are PVCs, there's some changes. Dr. Tucker, give me a knee-jerk response, an emotion that kind of comes across your mind when I showed you the EKG.
Well, it's not suitable for work, what I would say, but it's not good. I mean, you look at that EKG and you go, this guy's having a big anterior infarct, and it's scary, and you just got to get something done right away.
Right. Yeah. How about you, Ben? What's your thoughts on this?
Oh my, that's a very sick patient. It looks like a slam dunk, as Dr. Tucker saying.
Yeah. Well, slam dunk as it may be, but the issue is, how do we get the patient from the marathon tent to Dr. Tucker's cath lab safely, right? So the paramedics in this case actually did a great job. They recognized a STEMI, first of all. They called in a STEMI alert to us in the ED. And as a result of that, we were ready. And we are big on readiness. We were ready. Matter of fact, the cath lab team was waiting for the patient in the trauma suite. And if you saw the EKG, that's the only EKG we have. We never got a chance to do a 12-lead in the ED because one wasn't needed. Patient actually came through, and the first thing we do in the ED is just to whip out a checklist for STEMI care. And we did that, executed, got some medications he needed to get, and then off he went. I think his throughput time in the ED was literally like, a minute or so. So we went to the cath lab, and as you might suspect, he had a big bad lesion. He actually had 100% occlusion of the mid-LAD. Long story short, he had a hospital stay. He did fine. He was discharged back to what I hope is running marathons again. So that's the case, guys. And now I just wanted to open it up to some questions to both Dr. Tucker and Ben. But before I do that, let's not forget that heart disease is still the #1 killer, both in the U.S. and globally. And it does not discriminate, right? It doesn't discriminate between men, women, ethnic groups, no one. As a matter of fact, there are, I think something like almost 800,000 heart attacks a year, and something like every 30 seconds or so, someone's having a heart attack. The numbers are terrible. And it just so happens that about a third of patients who actually have a heart attack don't make it to the hospital. So there are risk factors, obviously. The big risk factors are what? You guys can help me out here. There's smoking, diabetes, hypertension, hyperlipidemia, family risk. There are lots of those things, but those risk factors are the classic ones. And today we're here to talk about some of the other things. How do you tell those things apart in a patient who's otherwise healthy? and an elite athlete, right? Why would you ever suspect they have these risk factors, right? So, so that's a really important thing to, I think, just keep in the back of your head. So, Dr. Tucker, let me ask you something. Athletes, right? They've got strong hearts, good hearts. How does the mechanism of a heart attack in someone like this, in this case, this athlete, differ from the mechanism of a heart attack in the general population?
Well, I think the ultimate final pathway is still the same, which is plaque rupture. Okay, so there can be a soft plaque, and we know from autopsy studies of people who've survived heart attacks that frequently the underlying stenosis is maybe only 20–30%. Okay, it's not that bad, which is why someone maybe wouldn't have any symptoms at all until they have a heart attack. It's pretty common knowledge in cardiology that 40–50% of people who present with heart disease present with a heart attack or sudden cardiac death as their first symptom. Okay, so your marathon runner, actually for us, not that surprising that it would happen that way. So you can, the sheer stress of a heart that's working super hard for a couple, 3 hours at a time in a marathon, the sheer stress on those arteries is significant. You throw in the mix that maybe in the Boston Marathon run in the winter or spring, or when is that done?
Yeah, in the spring.
But it can still be pretty darn cold, okay? So you've got the cold weather playing a role in vasoconstriction, theoretically. But it's really just the sheer stress on the artery. You've got maybe a vulnerable plaque that no one even knew about, a lipid-rich plaque, if you will. And that's all it takes for, I know it seems strange to the people who aren't doctors or nurses on the Instagram live feed here, but it doesn't take much to cause a plaque to rupture. It can be emotional stress that does it. It can be a sudden surge in blood pressure. You've seen people have this happen when they're in arguments. I had a patient who got in an altercation with his neighbor over their lawns, and it escalated, and the next thing you know, he's having a heart attack because his blood pressure shot up, his heart rate shot up. The classic example, and I don't mean to be too wordy, I'll wrap it up quick, but the classic example is the firefighter who goes from sleeping in his bed to running into a burning building several minutes later. There's just no time in that case for him to warm up. In your marathon runner, though, it's probably a little bit different scenario. He's been running for 20 miles. Everything's going great until it isn't. And for whatever reason at that time, dehydration, the plaque is vulnerable and it just decides to rupture, and that's that. And on top of the ruptured plaque, you get the platelets and the white blood cells and the red blood cells and the thrombin and all the things that contribute to completely blocking the vessel.
Yeah, I mentioned some classic symptoms. These don't sound, marathon runners don't seem to have these classic symptoms because they're running, right? So they're running, they're already sweaty, and they've got some degree of discomfort. So in athletes such as this, Dr. Tucker, what might we expect to see as symptoms in these elite athletes that differ from others having symptoms like classic central chest pain? Any thoughts on that?
Well, it might not be chest pain. Sometimes it's an arrhythmia. So they might just get suddenly dizzy or lightheaded and not really know that the heart is doing something abnormal, such as atrial fibrillation or even ventricular tachycardia, which is not at all uncommon in the setting of acute MI. So they might just have dizziness or lightheadedness while they're running and not quite understand what's going on. They might just simply feel more fatigued, like, why am I so tired? I was doing great and now I feel terrible. So chest pain is not actually it's not all that uncommon to not have chest pain. In fact, it's fairly common to not have chest pain at all and just not feel right. Maybe even just a sense of impending doom. I just know something wrong, but I don't know what it is. So we hear that a lot when people come in to see us, or when they're brought in, by the paramedics and stuff. So it doesn't have to be chest pain. And as I mentioned, he may not have had significant coronary disease in terms of angiographic disease. If you had cathed him an hour before the marathon, you might have seen only 20–30% narrowings here and there, which a lot of people in their 40s have. But there's something about the marathon and the stress that he was under that caused that plaque to rupture.
Yes, what I'm hearing is that you don't need to have a significant stenosis. There's something else, a trigger, that takes even a sort of a minor plaque and pops it off and goes downstream and causes a problem.
Yeah,
And
and
those
it's
triggers
and
might
it's
be,
and it's not even necessarily going downstream. It's just where the plaque actually ruptures is where the clot forms. Some people think of the plaque rupturing and going downstream, and it can do that. But more often than not, it's just the plaque ruptures wherever it is, and your artery, in a way to try to heal it, puts down those different chemicals and hormones and things that narrow the artery and blood clot. All of these things happen all at the same time and very quickly once the layers of the plaque that are not supposed to be exposed to the blood suddenly get exposed to the bloodstream. The artery is literally trying to repair a problem, and the repair itself, if you will, is what's causing the obstruction.
yeah, great. Thank you for making that clarification, because I think that's really the real pathology here, right? So excellent. Ben, let me just turn to you for a second now. Now, Ben Sadler here, he's an EMS expert, crisis management expert, and really done a lot of teaching in the past. What is your advice to paramedics coming up in this field, getting into the market here, and coming on to a patient like this, getting on scene to see a patient like the one we've talked about today, who looks like the way he did with that EKG? What's your advice to them?
Well, I think thanks, and thank you, Doctor, for that great pathophysiological, that was fantastic.
You're welcome.
First of all, the ongoing learning from when we have access to experts like you, Sush, and Dr. Tucker is so important for our pre-hospital team. So learning about how someone who's an otherwise healthy, even a elite athlete, could have an acute event like this is really important, so that it's not a miss, right? We don't want to have misses. But let's not forget the basics, right? Everything comes back to fundamentals. Like Larry Bird said all those years ago, it's all about the layups. So is this patient sick or not sick? And when you look at this patient, this is going to be a sick patient. You match that EKG up, and with the clinical presentation of a hypotensive, borderline hypotensive, pale patient, probably already sweaty from running, it all adds up to sick, and that trumps the any other otherwise healthy or less concerning kind of risk factor profile. It trumps it completely. But really sticking to our ABCs, that in the field we want to be stabilizing completely but quickly, and we want to be communicating, coordinating in a concise and direct manner to our hospital team, our ER, interventional cardiology team, and getting that patient to the right care and the right time and with the right communication in a concise, direct manner that our team knows that, and doing it in a way that Dr. Tucker and his colleagues can get that artery open and prevent this patient from having a worse outcome or, God forbid, a fatal outcome.
Yeah, and Ben, we know the training is everything. I've done a lot of EMS training, as you have too. But besides training, right, what kinds of strategies in terms of, I'm thinking systems now, right? Systems and equipment, infrastructure, what kinds of things would you do you imagine would be something we can actually do for taking better care of these patients?
Well, I think the continuum is really important. So having opportunities for access to education from our emergency medicine and our cardiology colleagues about scenarios like this and other ones that are similar is absolutely essential, and that ongoing refreshment, so that these cases are presented in a way that's positive reinforcement and constructive and really guided in continuum from the point of first symptom onset all the way through is absolutely essential. And we really look to our leaders like Dr. Tucker to help us with that and to help us always improve. I also think there are aspects of system design that we can always look towards and improve, making sure our access to AEDs, particularly in a very exciting time where there's talk about and there are places that are putting AEDs on drones now and getting them to see, making sure that if someone is having a chest pain or an equivalent, like Dr. Tucker described, that they're being transported always preferentially by EMS, so we can keep that patient safe or as safe as possible and provide the care that's needed to get them to intervention to get them to that cath lab and get that artery open and get them the definitive care they need, with the in time to save their life.
Yeah, thank you. Yeah, it's so important. All that stuff is just systems, design, infrastructure, training. It's just, it all has to come together nicely too, right? So, Dr. Tucker, I wanted to touch on something that Ben said, and that is sort of these strategies in the pre-hospital world are effective, right, in creating systems to get patients to us. In the EDs, we have things like I touched on, checklists, and we really do work very hard at executing these things effectively so that patients have minimal times in EDs and get to where they need to be with you. In your practice, though, can you share with us some strategies that you've actually implemented to reduce that door to balloon time?
Yeah, that's a great question, and thanks for asking it. Everything that has been said already is super important, but this is over 10, 15 years ago now. We were having, first of all, some trouble identifying patients with a STEMI before they got to the hospital. So what would typically happen is the paramedics would do an EKG in the field. They would think it was a STEMI. In the old days, what would happen is the patient would come to the ER doctor would do his own EKG. There would sometimes be, a few minutes delay, and sometimes, unfortunately, more than a few minutes before that EKG was done. Then a STEMI would be called, then the cardiologist would be paged, and the cath lab team would be paged. And as I'm talking, I think you can hear all the elements where a delay can occur. So we said, okay, forget that. We need to do something totally different. So we started working with, when I was the chief of cardiology and the chief of the cath lab, I've bequeathed those positions to a couple of my younger colleagues. But what we started doing was working with the Travis County EMS and the local county EMSs, because there's more than one around Austin, and said, we need to find a way to get the EKG to us quicker. And as soon as you make the call in the field that it's a STEMI, we're going to trust you, and we're going to activate the team then. So the policy evolved, and the policy now is when the EMS or the paramedic says that it's a STEMI in the field, the team is activated, okay? Multiple people get alerted at the same time. It's called a STEMI alert, and it goes simultaneously to the ER, to the cardiologist, to a bunch of different ancillary people at the hospital, including nurses, the ICU nurses, so they're preparing a bed, the cardiac recovery nurses, so they're getting ready, the entire 3 cath lab team members that are on call. If it's during the day, the whole cath lab gets it, not just the 3 people on call, but the whole cath lab staff, which is like, 15 people. So we're already either on our way in the same time that the ambulance is bringing the patient in, or we're already there. Now, we then started saying, okay, we need to get that EKG, so in case it isn't a STEMI, we can send people back home, or at least call off the STEMI alert. So it's taken a while, but we now have the technology to receive EKGs pretty reliably from the field, and we can tell if it's truly a STEMI or not. Sometimes, as you know, it's a pacemaker patient, and it's not a STEMI. Sometimes it's a left bundle branch block, which could be a STEMI. But if you know from old records that the patient has a left bundle, well, then you can call it off. But so let's just assume that it is a STEMI and we're all on our way in. So what we also figured out is, okay, well, we need to make it quicker to get the patient to the cath lab. So assuming that it is a STEMI and I've seen the EKG, then we are telling the ambulance to bypass the ER and say they literally come, I guess the stretcher rolls through the ER, but only for a few seconds, all the way up on the way to the elevator. And as long as a doctor and a nurse, along with the paramedics, are the cath lab doctor, me, the cardiologist, as long as a cardiologist and a cath lab nurse are there, we're comfortable taking that patient up because the EMS and paramedics are with them. So we've got at least 4 people going up to the room. And as I mentioned, we've got a whole bunch of other ancillary staff that are coming too. So we take them up to the room directly. We bypass the ER. We do not stop it go. We do not collect $200. We literally go straight up to the cath lab and get them on the table. It's a group effort, okay? So the paramedics are getting the patient undressed. We're helping get the patient undressed and draped. We're getting IVs, and we're making sure IVs are good. We're getting them on oxygen. we're getting a verbal consent. We're not doing written consents, and then we're ready to go. So literally the doctor is helping, the cath lab tech is helping, the nurse is helping, the paramedics are helping. We're getting the patient on the monitor. We're getting them hooked up to everything they need to be hooked up to. All of these things take time, but if you do them simultaneously, you can save a lot of time. We have the fastest door-to-balloon times in Austin, Texas. We typically average 37 minutes. My personal record is 12. One of my partners said he actually did it in 11, but I want to see proof of that. But, you know, we take pride in the fact that we can get these patients on the table, get a catheter in, and get the pictures and get going. I could go into more details of the actual cath itself that can save a couple minutes of time. I don't want to hog everyone's time, but the bottom line is several things have made a big difference, including notification from the field. The team is on the way in. We're not waiting for them to get to the ER and have the ER doctor, God bless you, I love you, but we're not waiting for you to confirm it. We're going to come in and maybe we meet them in the ER and take a quick look at the EKG. And if there's a doubt, well, then we can always, you know, put a brief hold on things and do an EKG in the ER if the one from the field is not conclusive. But if it is conclusive, we're going straight up. The only other thing I would mention that we did that has helped a lot is we got parking spaces that are called STEMI spaces for the cath lab team. So those are right next to the ER. So when it's after hours, they don't have to park in the garage. They don't have to park several hundred yards away, which is great, honestly, for some of our employees late at night to not have to worry about the safety of that, right? Mm-hmm. They get to park in a well-lit area right next to the ER, and they're literally 5 seconds from the ER door. And that has saved another couple of minutes, okay? So we whittled down our times from over 60 minutes down to an average of 37, and it is not uncommon to have door-to-balloon times under 20 minutes when we know they're coming.
Well, that's something else. You're talking about the cumulative benefits of incremental gains, right? It's been talked about before in the world of sports, and here we go. Once again, it's being applied here. Hey, folks, just in case you didn't get that, interventional cardiologists, being one at least, is being a competitive athlete, as you saw. They're quite they're quite competitive, obviously, between each other too. So you've got the best record, you think, Dr. Tucker?
I don't know. I don't want to say that. Not on Instagram.
You're not sure.
All I'm saying is I'm happy with the times I have achieved. I'll leave it at that.
Mm-hmm. All right. Well, my money's with you, my friend. All right. Very good. So. Folks, make sure you're writing your questions in. We will try to address a few questions at the end of this, and the rest come in. We'll get to you later on, but keep putting your questions in so we can get to some of them at least. Dr. Tucker, I've got another question for you. I get asked about this sometimes. Can you talk a bit about the screening tests for athletes? Screening tests in terms of things like, we know about history exam and EKGs, obviously. Yeah. But how about echo and stress testing and coronary calcium scores? Yeah. What is the meaning, the reliability, and are they good in identifying high-risk people?
Well, let's first, since you're talking about athletes, in Austin, Texas, for over 20 years now, we've had programs at the schools where echoes are available at either free of charge or like $10, where we do a quick echo of the high school athletes. And I think a lot of the college athletes get screened by echo as well routinely. And I'm pretty sure most professional athlete teams are doing that. The echo is very good at looking at things like hypertrophic cardiomyopathy, which is probably in really young people the #1 cause of out-of-hospital cardiac arrest. The echo is also good at looking for aortic valve stenosis that you didn't know somebody had. Maybe a bicuspid aortic valve in a young person. So that's another thing. The echo is also good at looking at dilated cardiomyopathy. And those three things are probably the most common three things you would see associated with cardiac arrest, in a young person, like a really young person. But when you're talking about the athlete who's in the middle ages, like in their middle age years, like a 40-plus-year-old or really a 35-plus-year-old athlete, far and away, the most common etiology of their heart attack or cardiac arrest is going to be coronary artery disease. We know that plaque formation starts when we're babies. Smooth plaque starts forming in the aorta before you're, probably 3 or 4 years old in this country. So coronary artery disease is far and away, just atherosclerosis, garden variety atherosclerosis is far and away the most common thing that would cause someone to have a heart attack after age 35. Do they have the other things? Yeah, they can happen, but that's the most common. But to answer your question about screening, so for the young people, we've kind of already talked about, screening for symptoms. The most important symptom I think to ask a young person is, have you ever fainted during exercise? Or have you had chest pain during exercise? But fainting during exercise is a really big red flag. That's an immediate referral to cardiology and most likely electrophysiology as well. But let's talk about your patient, the 40-plus-year-old. Calcium scoring is good. I use it all the time. Keep in mind that for soft plaque, it's going to probably be negative. It's going to probably be a 0. But for most middle-aged people who have significant coronary disease, the calcium score will be elevated. It may only be a little bit elevated. It might be 10 or 20 or 100. I've seen 10,000, but that's usually in a much, much older patient. Stress testing is very useful. It's very useful for picking up, fixed, significant coronary artery disease. Stress testing is unfortunately not useful for finding minimal coronary disease or mild coronary disease or rupture or plaques that are about to rupture. Not very good at that. A better test in someone who's having symptoms, and you can't really find much on the stress test, would obviously you have cardiac catheterization, but a less invasive way is coronary CTA. And the coronary CT scans nowadays can do fractional flow reserve. We can actually measure the flow in the arteries, and we can look at those plaques in a lot more detail, and you can see soft versus hard plaque with the coronary CTA, and that can give you an idea of someone who's at risk.
Fantastic. Well, it's changed the world, right, from 10 years ago, I'm sure.
Yeah, and the coronary CTA, which we had 15 years ago, as you can imagine, it's way better now than it used to be.
Yeah.
And the guys who read it are really, really good at this stuff.
Yeah. I've seen some of that data too. It's just fantastic what it can actually tell you, right? So, another question I get asked, not that infrequently, is like this guy here. Yeah, so he's had a heart attack, he's had a coronary event. What do we tell patients like this after they've had a coronary event, especially like in getting back to training and getting back to their competitive sports? What's your advice to them?
Well, I might be a little bit more conservative than other people on that topic, but I don't tell them they can't do it again. But I do tell them you need to take a big dose of reality here, okay? For whatever it's worth, you had a heart attack, and it happened while you were doing this fairly extreme event. And we can reduce your risk of that happening again by, treating you with aspirin, statins, maybe even beta blockers, which, by the way, marathon runners won't like because, number one, a lot of them already have a low heart rate and you can't give it to them. But if they don't, it affects their exercise performance. So I do tell people, you just have to keep in mind that you're in a different subset of patients now. You're someone who's already had an event, and a life-threatening one at that. So I typically recommend that they perform moderate exercise, they do it regularly, and they enjoy it. Am I going to tell them, yeah, you're fine to go run a marathon again? No problem. I could never guarantee someone like that they wouldn't have another issue. They want me to. My runner patients are super competitive. They're type A. They want me to tell them, oh, you're going to be fine. Go run. You can run all you want. I don't think I can honestly say that. They might be fine. They probably have a pretty high chance of being fine. But do they have a 100% chance that something bad won't happen once they've already had a heart attack and a stent? I think that's tough. I mean, I'm just being frankly, brutally honest. And I tell them that. And most of them are actually fine with it. They can still run. They can still exercise. But, marathon running is a different animal. That is putting your heart under tremendous strain. For most people, a minimum of 3 hours, and probably for more than that, 4 hours or more. These guys aren't running 2 an hour and 10-minute marathons. They're in the 3-hour category, 3.5. So that's a bit of a long-winded answer, but you have to tell people there is a risk going forward now that you've had this event. You're not at the same risk level you were before.
Right. Yeah, it's a tough thing to hear, but I think they have to got to hear it, right? You got to be honest with them for sure.
Yeah.
So, what about things like medications? Do they need to be on some of these medications? You touched on a beta blocker, but how about other things like aspirin and other anticoagulants? Are you putting on these medications for the rest of their life?
Well,
Number one, and the second part of that is, what is the role of them actually? Are they done? They're out of the chute. They're good to go, or do you actually follow them closely as a cardiologist over the rest of their lives to make sure that they actually they're in good standing?
yeah. No, I mean, first of all, they're going to be on aspirin the rest of their lives. That's what's called a class 1 indication, which means everybody agrees that it's valuable. They're going to be on a blood thinner in addition to the aspirin for a year following their heart attack. There's several different ones out there, Plavix, Brilinta, Effient. They're going to be on one of those if they had a stent. Okay, so for a full year, that's the recommendation after a heart attack. So they're going to be on those two for sure for a year, aspirin indefinitely. It's also a class 1 indication, meaning everyone agrees it's valuable. If they're not allergic or don't have problems with statins, that everybody who's had a heart attack should be on a statin. And the reason for that is statins actually help stabilize the endothelial lining, the lining of your blood vessels. They actually change the morphology of your blood vessels to a healthier, safer blood vessel in terms of the risk of future plaque rupture. Statins don't just and statins have side effects. We all know about that, and they're not for everybody. But statins don't just make your numbers look prettier on a piece of paper when you go to your internist or your cardiologist. They actually are changing the morphology of your blood vessels, and because of that, they are reducing the risk of future heart attacks and future coronary events. In terms of beta blockers, as I mentioned, most runners who have low heart rates to begin with are not going to be able to take a beta blocker. But in the athletes who have a heart rate above 55 or 60 and can take it, if they've had a heart attack, a beta blockers indicated for the first year. And then after that, if they don't need it, if their blood pressure is good, they could be weaned off of it. But I think the long-term medicines that they would take perhaps indefinitely is aspirin and statin, possibly a beta blocker if they can tolerate it. And then, of course, there's other issues like diabetes control, et cetera. And the last part of your question was about follow-up. No, they don't get dismissed out the door once they're good with their heart attack. I mean, once they've had a heart attack, frankly, they're my patient for life until I retire or they go on their merry way somewhere else. But they're going to see me probably 1 month after the heart attack, 3 months after the heart attack, and then if everything is going great, 6 months after. Every 6 months thereafter, and then there will be some periodic stress testing to make sure everything looks good.
Terrific. Well, what a wealth of information you are. It really is quite a treat for me, at least, to learn all these things. So thank you so much.
Welcome.
And too. Now, guys, this has been great. I know there's some questions out there. I promise we'll keep this not too long. So I see some questions here already. I'm just going to take on a couple of them. This is for Dr. Tucker. There's a comment here: DeWinter's syndrome, DeWinter's versus electrolyte abnormalities. I guess the question is, what's your take on that? How can you tell those two things apart?
Okay, say the first part. Winters?
DeWinter's T-wave morphology.
I think I didn't hear you correctly.
Yeah.
Say it again. I'm sorry.
It's called DeWinter's T-wave morphology. It's like a STEMI minical. It's like a morphology in the anterior precordial T-wave.
Right. Yeah. I think we had another name for it. But what is the question about it? Does that portend?
Yeah, I guess what the question is DeWinter's versus electrolyte abnormalities. How do you tell them apart? Is what I think the question was leading up to.
I see.
Hard to tell, though, I think.
That would be a little bit more involved discussion that probably need to take offline, but you can get some very funny T-wave changes with electrolyte abnormalities, whether it's low potassium, low magnesium, low calcium. Those things all can cause things from QT prolongation to kind of just non-specific T-wave changes. Of course, an elevated potassium gives you a completely different T-wave, typically kind of peaked. before the QRS starts widening and all of that. When I think of the biphasic T waves, like of a Wellens criteria, that's the name I remember is Wellens criteria, where you kind of have these kind of biphasic T waves where it goes up and then it goes down below the baseline. And so it's kind of, up and then down below, and you see that across the precordium. We consider that very concerning for a proximal left anterior descending stenosis, but I've also seen it in completely normal hearts, so not particularly helpful. Right. I don't know if I answered your viewer's question correctly, but
yeah, it's a tough question, right? Because electrolyte abnormalities, I'm sure all athletes are going to have. This guy has some concerning, morphology, I guess, but
and actually, well, not to interrupt you, but like I've seen some very unusual EKGs in cyclists who have really low heart rates, runners who have really low heart rates. Those are not uncommon to see that, and some of these trainers, especially long distance cyclists and rowers, they have enlarged hearts. Okay, that's how they are able to have such a huge stroke volume to do the sports that they do. They literally have enlarged hearts, and so those hearts have abnormal EKGs frequently. So it isn't easy to tell just looking at the EKG what the problem is. They're going to need something, an echo, a stress echo, maybe even a cardiac MRI, coronary CT, something.
Right. All right. So, hey, Ben, this is for you. It says the question from our audience is, in the pre-hospital arena, do you see more arrhythmias with certain types of heart attacks? What's your experience?
That's a great question. I feel like, anecdotally, when we have the right-sided, involvement in IMI or more proximal right ventricular infarction, posterior involvement, as we get, the bradycardias and arrhythmias. Not that we don't see that in anterior as well. If we have, the septum involved and, we get a really sinister complete block with like a ventricular escape rhythm, that's very concerning. I'm sure that's something in the cath lab that wakes everyone up. But I think we often see the ventricular arrhythmias when in those cases where, Dr. Tucker spoke about VTAC, right? When oftentimes you have a big anterior MI and you get that circus movement on the front wall, and we'll see ventricular tachycardia, and that's something that paramedics seem to be vigilant for and on top of, so we can manage that with cardioversion, or if it's pulseless, immediate defibrillation, and get these patients into the interventional team, get that flow managed.
Yeah. I think arrhythmias seem to go along with hypoxic injury, right? Am I right? So when I think a big bad MI is going to, like this case here, probably would be more likely to see something like that. So Dr. Tucker, question here is, you're getting tough questions here. It goes, do you see a lot of type 2 MIs with a history of Prinzmetal's angina and no CAD?
Oh, sure. Yeah, we see that all the time, women especially. But, there's Prinzmetal's angina is fortunately not that common, but it's more common in women. And they can have elevated cardiac enzymes if they have a long enough episode of chest pain with their spasm, because basically the spasm is either completely narrowing or partially narrowing the coronary artery for a long enough time that it's causing discomfort. And so therefore the heart, it's causing discomfort because the heart is ischemic. And now our troponin elevations are this blood test that we do called the troponin, for those who are not medical people in the audience. It's a very, very sensitive test nowadays. And so it goes up with just a minor amount of myocardial ischemia, or just heart muscle not getting enough blood flow. So yeah, we see a lot of mild troponin elevations in people with don't have significant coronary artery disease. Type 2 MI can also be associated with all sorts of other metabolic conditions. So if the heart is put under stress for any reason, such as prolonged low blood pressure from, let's say, an infection or sepsis or pneumonia, or just bad dehydration, and you're not resuscitated quickly, there's a myriad number of reasons for why the not type 2 MIs can occur without underlying coronary artery disease. It's just if the heart muscle for a long enough time is not getting good perfusion, good blood flow, basically because of low blood pressure or low heart rate and low oxygen levels, or some combination of all three, you're going to have a little bit of a troponin elevation in the bloodstream. And there's all sorts of non-cardiac reasons why that happens, but probably septic shock would be one of the most common that we see in the hospital.
Right. Great question, by the way, and thank you for that answer. It's perfect. Here's one. This is like, I might as well ask this question. So, can a person get a heart attack in the gym, even if they work out regularly in the gym?
Of course. Yeah, sure. It can happen anytime.
Yeah. Have you seen something like that, Ben?
Oh, sure.
In the gym, on a treadmill and down? It's pretty.
Absolutely.
Yeah. Here's one, Dr. Tucker. It says, what is the percentage of recurring events of MI? Had a heart attack.
Okay, so you mean what is the likelihood of it happening again?
Percent of recurring MIs.
I'd probably have to get out my textbook to give you an exact number, but suffice it to say that it's significantly higher than someone who's never had one. Okay, so number one, there's that. But having said that, I've got literally hundreds of patients who've had heart attacks who've never had another one, and you can really, I think the better answer is, well, what can you do to prevent it from happening again? And the most important thing you can do is to really start following the recommendations of your cardiologist or your internal medicine, your primary care doctor, your ER doctor. Take care of yourself. Whatever you're doing that led to it, stop doing it. So if it was smoking, diabetes control, blood pressure management, cholesterol, lack of exercise, start taking care of all of that stuff. That's how you reduce the risk of a future event from happening. That would be the most important thing, the bottom line. And the other thing that I think is important to say is you kind of mentioned earlier about family history. I like to tell my runners, you can't outrun your genetics, okay? I mean, you are what your parents gave you. And if you've got a really bad family history of premature heart disease, and by that we mean in men under 55 having their first heart attack or their first stent, and under women probably under 60. So if you've got that family history of first degree relatives, mother, father, brother, sister, in your family, it's not as big a risk factor if it's an aunt, an uncle, or a cousin. But if it's a first degree relative, mother, father, brother, sister, that has had a premature cardiac event, you're at risk. And you need to be getting yourself looked at if you've never had a problem so that you don't have a problem. Start controlling your risk factors early.
Yeah, I think you're so right. So right about that. That's right. Anyhow, hey, listen, that's all the time we have for questions from our audience. But folks, like I said before, we'll answer all your questions. Send them up to me or to the CardioVisual folks that were there. We'll get them all answered. Dr. Tucker, before we go, any closing thoughts for our global audience here tonight?
Well, first, just thanks for having me. Second, just realize that if you do ever have a heart problem, or you know someone who did have a heart problem and they survived it, just keep in mind that there were a whole lot of people involved to make that happen. It wasn't just the cardiologist. It was the paramedic you see here on the screen. It's the ER doctor you see here on the screen. It's the people in the field who did bystander CPR. It's the nurses. It's the respiratory therapists. It's the people who drive the ambulance. It's everybody. It really is a huge effort to get someone through a heart attack safely and successfully and back to enjoying their life with their families and their friends and their workers. So if there's anything I would say, it's don't take the medical system for granted. We're here for you, but we're working hard for you. And just realize there's a lot of people who take care of things like this who, deserve a pat on the back every now and then. I don't need it, but there's a lot of people who are unsung heroes who do. So I'll leave it at that.
Well, thank you so much for that. Wonderful. How about you, Ben? Any closing thoughts for this evening?
No, just thank you so much, Serge. Thank you so much, Dr. Tucker. It's fantastic.
Yeah, thank you. I've enjoyed everything you guys have said. So.
Thank you, sir. I would just conclude by saying, as far as EMS, is I'd encourage, if anyone's having symptoms or you observe or know someone is having symptoms that you care about or you're caring for, outside of the hospital setting. Make sure that you activate EMS early and often. Like Dr. Tucker said, not just for chest pain, but if someone's having symptoms that might be an equivalent to chest pain. They're feeling like they're going to faint. They're having skipped beats. They have that sense of impending doom. I think that's a really important one. And it's otherwise unexplicable and sudden. That's the right call, is to make to 911 and get paramedics to you so that we can keep you safe, keep you stabilized, and get you to the right care and the right time.
Terrific. Hey, thank you for that, Ben. That was really great.
Good stuff.
It really is. Dr. Tucker, Ben, my guest tonight, thank you so much for taking the time to be here with us. And on behalf of the entire faculty at CardioVisual and My Heart AMD, this is Sush. Have a great night and be safe.
Welcome.
We'll see you next.